Hello, my name is Yejun Ho. I'm a medical student in the University of Calgary, and our team is here to explain a special topic, which is ophthalmic complications that can be observed in various OR procedures relating to anesthesia. Despite the relatively shorter OR times per surgery and the longer clinic hours, ophthalmology is a surgical specialty. And this is where a link between ophthalmology and anesthesia is introduced. There can be lots of precautions that needs to be taken and kept in mind when dealing with the ophthalmic surgeries to preserve vision, but generally there always needs to be precautions to not accidentally injure the eye for any types of OR procedures. Further, focusing more toward ophthalmic surgeries, there are many unique procedures and anesthetic medications for the eyes specifically. Lastly, while the patient is under anesthesia, watching for the patient's vitals is very important. We need to make sure that the artificial respiration rate is maintained at an ideal rate, and also that heart rate and the blood pressure is maintained. However, stimulation of the eyes can negatively impact this homeostasis, and this is called ocular cardiac reflex. A certain pressure on the eyes can induce a slowing of the heart or bradycardia. So the topics that we'll cover today from an anesthetic point of view are as follows. First, post-retrobulbar block apnea syndrome, severe pain that can be experienced in the OR, emesis, conjunctivitis, and several anesthetic procedures, of which we've selected 6. Post-retrobulbar block apnea syndrome is the temporary termination of breathing, or apnea, after the injection of anesthetics behind the eye. This is called retrobulbar block, and this can induce this apnea. While attempting to inject behind the globe, the needle can accidentally puncture the optic nerve sheath, and when that happens, you'll actually be injecting the local anesthetic into the nerve sheath. This will escape the meaning of local entirely, because the anesthetic that has been injected into the nerve sheath is then connected throughout the central nervous system via CSF or cerebrospinal fluid. One structure that we should keep in mind within the central nervous system is the brainstem. Brainstem is responsible for breathing and consciousness, and the affected brainstem with the anesthetic will not be able to activate and maintain breathing. The post-retrobulbar apnea syndrome can occur within 20 minutes of accidental optic nerve injection, but it usually resolves within an hour. It's not a fatal or threatening condition. Because of this spontaneous resolution, the treatment would be supportive. We just need to maintain the ventilation and make sure that the oxygen is being supplied within the patient. A contraindication to starting a retrobulbar injection in the first place include a bleeding disorder, in the fear that you might not be able to control bleeding once we go retrobulbar, open eye injuries, and extreme myopia. This is a long globe such that the light converges in front of the retina. Generally, greater than 26 millimeters. While under anesthesia, the patient is basically absent for that period of time. The body is not aware of what has happened in the body during anesthesia. And waking up is not as simple as waking up from a nap. There are a lot of changes that happen in the body as the body takes over voluntary breathing and also wakes up from a lot of anesthetic medications that are injected. If you happen to undergo general anesthesia or are presenting yourself in an OR setting, it will be important to note a symptom or a sign of severe pain. If the patient has severe pain that in their eyes, it could be a sign of intraocular hypertension, which is increased pressure from within the eye, either from a primary problem from within the globe or due to compression from the orbital region, or corneal abrasion, where there's an epithelial defect on the cornea. This could happen especially if the patient's eyes are not taped properly and there is damage from exposure to the air or from inappropriate contact with the eye, with an object. Stimulation of cranial nerve 10, or the vagus nerve, can be a common post-operative problem after eye surgeries, and that is especially the case for after strabismus repair. Strabismus is, as you can see on the right hand picture there, is the misalignment of the eyes. And the vagal stimulation can cause emesis. That is a medical term for vomiting, throwing up. And Valsalva and the increase in the pressure from the act of vomiting can have adverse effect on the eyes and the overall outcomes from the surgery, especially if it's an ophthalmic procedure. There are still sutures and artificial injuries from which the eyes are healing, and undue pressure from Valsalva and emesis can prevent those injuries from properly healing. So, preventative IV administration of drugs for nausea and vomiting is quite strongly recommended. One thing to be aware is anesthetic drugs are still drugs. Like any medications, patients can have allergic reactions to anesthesia. So before surgery, it is always important to note if the patient has allergies to anything, from drugs to latex to any other materials. An emergency situation would be anaphylaxis or life-threatening allergic reaction, and there are a whole host of symptoms and signs that you can note on the side there, and hypotension and tachypnea and short of breath are among them. If you're wondering about a clinical sign of anaphylaxis under anesthesia, you can look at the eyes as well. If upon exam of the eyes there is conjunctivitis bilaterally, this can signify anaphylaxis. First of the procedures that we will talk about is retrobulbar injection of local anesthetics. And as mentioned way back in the first section, post-retrobulbar block apnea syndrome, Retrobulbar injection means you're injecting anesthetic agents right in the back of the eye. So naturally, this is a very tricky procedure. So there are quite a few complications that could potentially arise with retrobulbar injection. This can include retrobulbar hemorrhages, globe perforation in extreme cases, optic nerve injury, as we've seen before, you can accidentally go through the nerve sheath, intravascular injections, and if you do accidentally inject in a blood vessel, there will be immediate convulsions by the patient. Ocular cardiac reflex, where the stimulation of the eye, for example, you might be pushing on the eye to get to the back of the eye. This can cause sudden bradycardia. Trigeminal nerve block, this is cranial nerve 5, mostly responsible for perception of facial sensations, and you might accidentally be injecting there. And actually, first branch of the trigeminal nerve is known as the ophthalmic branch, and it does enter the orbit. Respiratory arrest can occur rarely with the injection into the CSF, and very rarely there can be a trigger for acute neurogenic pulmonary edema. The second topic we will cover in this chapter is injection of the local anesthetic into a vascular system, and we covered this in the very previous slide actually. If the anesthetic intended as a local agent is injected into a vessel, this means that the anesthetic medication has access to the systemic circulation, and it can therefore have effects all over the body. The artery with the greatest risk of being accidentally injected an anesthetic agent is the ophthalmic artery. This artery arises from the internal carotid artery. And apart from the fact that the internal carotid branches directly from the heart and also connects the entire head from the body, to touch upon the most important point, the internal carotid artery also feeds into the circle villus, and that is shown below as an inferior view of the brain and its vasculature. The circular shape defined by the anterior communicating artery, the pre-communicating anterior cerebral artery, the internal carotid, posterior communicating artery, and the posterior cerebral arteries is the circle villus. And when the injection goes from the ophthalmic artery to and eventually reaching this circulation, the effect is instantaneous seizure. We would like to avoid that, if at all possible. Peribulbar blockade is an injection above and below the orbit. This is also a local anesthetic and aimed into the orbicularis oculi, and that's the muscle there in the far right picture. And this is aimed to block the ciliary nerves as well as cranial nerves 3 and 4. Cranial nerve 3 controls the levator palpebrae superioris, or opening the upper eyelid, as well as the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique. Cranial nerve 4 innervates the superior oblique, which is responsible for abduction of the eyes, depression of the eyes, and the intorsion of the eyes. However, it does not block cranial nerve 2 or the optic nerve, which is responsible for perceiving the light. Complications that can arise from this peribulbar blockade is periorbital ecchymoses, which are large areas of erythema, and transient blindness. Several contraindications directing us away from performing peribulbar blockade in a patient is if the patient is under 15 and they have uncontrolled cough or tremors, if the patient is also disoriented or has a mental impairment, we would stay away from the blockade, bleeding or coagulopathy, or if this is a surgery of a perforated globe, then there will be no peribulbar blockade performed. Sub-Tenon block is an injection between Tenon's capsule and the sclera. Tenon's capsule is a sheath of the eyeball, basically, and a thin membrane that envelops the eyeball all the way from the optic nerve, which is the back way in the back of the eye, where the optic nerve exits the globe, all the way to the corneal limbus in the front. This membrane acts as a barrier of the eyes from the orbital fat and allows the eyes to move in an isolated space. Compared to retrobulbar or peribulbar blockade, the Sub-Tenon block has significantly less complications. However, we still need to worry about globe perforation, hemorrhages, cellulitis in the orbital region, and just because there is a high concentration of nerves in the ocular, local anesthetic spreading to the CSF and causing apnea. Regional facial nerve blocks improve the degree by which local anesthesia exerts its effects, and this method of block is great for large wounds where cosmetic repair may be required. The facial nerve blocks can be differentiated according to 5 different regions of its application: mental, or the chin area, infraorbital, supraorbital, and the supratrochlear, and the auricular, or the ear region. One complication that can arise from facial nerve block is subcutaneous hemorrhage. Last but not least, knot bath technique is a form of facial nerve block. This is performed by inserting a needle right in front of the mastoid process at the skull base, and then the needle goes superiorly and posteriorly, so up and back, in the direction of the stylomastoid foramen. This is not a recommended technique because this technique may block the facial nerve as it exits the stylomastoid foramen under the external carotid canal. This area is also very close to cranial nerves 9 and 10. The complications that can arise from this technique is related to the anatomic effects of the cranial nerves 9, the glossopharyngeal nerve, and 10, the vagus nerve. The specific complications are vocal cord paralysis, laryngospasm, and dysphagia, as well as respiratory distress. So here is a summary of all the complications and procedures that we've talked about. This is the reference that we used to create this video. And this is what we used for images. Thank you for watching.